Oh, this is like
We're doing it live.
Doing it live in person.
Yeah.
awesome.
Yeah, we're doing it live. Yep, we're live now. We just got a countdown going. So there you go. They can hear everything we're saying.
Ooh.
Oh, that's cool. You can see if people come on.
Yeah, you can see if people come on.
I can't see you guys at all, by the way.
I know. It's coming. It's coming.
Okay.
I promise. 5 seconds.
And then the new year.
I'll be patient.
2, 1.
Woo! We made it with Kennedy and Bella. Yay!
And Dalton.
And Dalton. Yay! All right, everybody. So we got Kennedy Davis here with us today. Incredible nurse in hospice, getting into the ER stuff. You've been one of my childhood friends from Crystal Palace in Las Vegas. We go way back. So we wanted to have you on the podcast because you're just like the realest nurse that there ever was. And outside of the podcast, we're always talking about all your fun stories in hospice care and how people throw human bags of shit at you and then, you backhand them. I'm just kidding.
Yeah.
Internally back.
Yeah, exactly.
Mhm.
So, anyways, we know that you've worked in the emergency rooms and you're working towards that again, going from hospice care. It's in a couple weeks, right?
Yeah, we'll see how it goes. So I did a lot of rotations over in the ER. And now I'm just trying to get back on with them full time. So we'll see.
Yeah.
But I've been doing home health and hospice for about 7 months now. So
Mhm.
and before that, I was a psych nurse.
Yeah.
Mhm.
Okay. So now I'm curious because what the goal of this podcast is just to unite people who help other people. And
Okay.
so I feel like you of all people have the most experience with understanding what happens at the end of life, like the psychology of the end of life. So what do you think that you've seen on people's worst days at the end of their life, or is there things that people typically regret, or what is the tones of people's energy,
Yeah. So a typical hospice story is when they are so sick that we are being brought on as hospice. We are seeing them at their denial stage a lot of the times. So a lot of the times I come in and they're like, well, I'm not going to die tomorrow. I'm like, no, you're not going to die tomorrow. And then you watch this denial and then acceptance and then grief. And the grief for a patient lasts the longest. Denial and acceptance kind of come back and forth and they just play off of each other depending on the day. But almost every visit I see with the patient, they have grief. And they're grieving the lives that they wish they would have lived. They're grieving the lives they want to live. They're grieving relationships with family members and relationships with God a lot of the times. There are patients that I have that have a lot of drug related history. And so a lot of the times they regret it. They're like, I wish I would have not started smoking when I was 14. Or I wish I hadn't done as many drugs as I do now because now my body is failing me at 61. I have patients that have ALS, so Lou Gehrig's disease. So they're losing control over their entire body and they just cry and grieve because they can't get up and go to the bathroom like they used to. They can't feed themselves like they're used to doing. And I think that's the most common thing is the grief that we see from mistreatment of their bodies their whole lives, and then they just regret not taking better care. And a lot of people, when they get older too, they just give up. They say that they're done. They stop taking their meds and they stop exercising. They stop doing things that normally they would do. They start eating worse and then they regret it because that end stage is a little rougher than it probably needed to be.
Right.
But there are other things where, like other diseases, where it can't be helped. So we also see grief where they're just sad because this disease has taken over their lives and it's not anybody's fault. It just happens. So,
Yeah.
yeah.
So how do you do you have something that you do that you prepare mentally to come into this you really don't know what you're walking into, I imagine, right?
I have no idea a lot of the times. Actually, I have a great story for this one. Um, so there are a lot of times where I walk in and I pull up to like a house and I'm like, that is 4 walls and that's it. Like that's not even livable. So there are definitely times where like I've walked in and it was the front door was a piece of plywood with a shower curtain rod, like a shower curtain rod and a shower curtain to cover it. And that was it. That was the front door. And it's December. So we're in Utah. It's snowing. And like his only source of heat was a little um a little oven, like not an oven, but a stove top. That was his heat. Um and I had no idea. I didn't even know that I was at the right address because it didn't look like a government issued address. So we get things like that. We get a lot of patients, like when we receive their orders, we don't get to know what their social circumstances are, like their family ones. So there are times where I come in and it's a frail older man that completely alone. Nobody to take care of him, nobody to help him. Like he is 100% by himself and he can't even feed himself. So we just we walk in and just try and assess. Like that is the number one from day one when you go into nursing school. Day one is assessments. And for 2 years of nursing school, you're learning how to assess physically, how to assess environmentally, how to invest social or assess socially and behaviorally. So you walk into a house and I'm tracking every little thing that's going on in the house. I'm tracking every relationship that I can see in the house. I'm tracking his entire physical body, the way that his skin looks, the way that he holds himself, the way that he talks, even the way that they swallow. Like I'm literally watching every little thing. And you just have to like internalize a lot of it and chart as much of it as you can. And then you go back to your car and you take a second and just like decompress for a minute. You like write it all down, put everything together really quick, do what you can for that person, and then you're on to the next one and you move on to the next one. You have to just forget about what you just saw and start completely over again. So, but it's hard. Like you have no idea what you're walking into. I just the other day walked into a patient's house that the only thing I knew is that she had wounds. That was it.
Mm.
I knew that there were 4 of them. And then when I looked at the wound care orders, they were so basic, like easy, nothing to do that I was like, why am I even doing this? Like they
Yeah.
must not be bad. When I walked in, I had no idea she was a paraplegic. I
Okay.
had no idea that she was completely incontinent. So meaning like catheters, briefs, everything.
Huh.
And I still hadn't even seen her pictures of her wounds. We had measurements and I thought, okay, they're kind of big, but there's no wound care really for them
Mm.
until I saw them. And the one is bigger than my hand, both
Wow.
ways.
Wow.
And it is so deep. I was seeing muscle, like it is like a giant cavity. So you
Crazy.
could like, I could stick my hand in it and grab that whole muscle if I wanted to.
That's crazy.
Yeah. Um, and then the other three were all about the same level. They were just probably like that big around.
Yeah.
So there were four in total that were so necrotic, and you could see that she was in pain, but I was like totally unprepared. Had no idea that that's what I was walking into. Everybody had downplayed it. And so thankfully I'm a walking ER and I have a giant suitcase that is wound care. So thankfully I had a lot of things I could work with, but
Mhm.
yeah, there are times you just have no idea what you're walking into at all. At all.
Yeah. Yeah.
Mhm.
Wow. So, so Dalton was sort of alluding to this, but how do you as an individual, I know you said you just get in your car, take a deep breath and kind of move on. Do you have any personal rituals that you do when you
Mm.
at the end of a day or at the start of a day to like not take these people's lives in you
Ooh.
in some ways?
I'm still working on that one.
Yeah.
I'm Yeah, I really suck at that actually.
Yeah.
It's really hard because it's like the most basic nursing school answer. They ask you, why do you want to be a nurse? And you say, because I want to help people.
Right.
Right.
Okay, so then they tell us to not take it personally and like don't take it home with you and all this stuff. And you're like, but I want to help people. So it's
Yeah.
really hard, right? Like a lot of nurses have this personality, and I know a lot of healthcare providers in general have this type of personality where they want to help, they want to take it on, and they genuinely care about people. And
Mhm.
so, um, like personally, whenever I have students follow me around, I always recommend that they find a therapist. Don't have to see him as often as you need, but therapy is 100%. Like, do it.
Yeah.
Because I've seen some pretty horrific things in my time in the hospital, in my time in the OR, in my time in the ER and in hospice. I have seen horrific things, and you can't go home and like share that with your spouse who's like an accountant or something. Like they're not going to
Yeah.
understand what
Yeah.
you know what I mean? Like
Yeah. Yeah.
they have no idea. And a lot of your friends, like, no. Like my cosmetology friends are not going to understand that. Like
Yeah. Yeah.
it's just different. So finding your people. I try to surround myself with a lot of nursing friends, a lot of healthcare friends that are like that same gallows humor.
Yeah.
Gallows humor gets you through a lot.
Yeah.
Sometimes you just have to like laugh at the fact that somebody pooped in a bag deliberately just to throw at you.
Yeah.
Yeah. Yeah. Yeah. Yeah. Exactly.
Saved it just for me to
Yeah.
throw at
Yeah.
me.
Yeah.
So you just have to like laugh at things like that.
Yeah. Well,
So
at
I try
least
and
they have,
find,
you know,
yeah,
come on.
yeah,
Yeah. Premeditated, at least.
it's
It was a
premeditated
goal.
poop.
Yeah. It
Yeah,
was a goal.
This is true.
It was a goal.
yeah. So you just gotta laugh at it.
Yeah.
And then I think one of like the best pieces of advice I got from a coworker, actually, she's been in home health and hospice in several different states, and just a long time, but she she told me that I didn't have to be tough. I'm allowed to just like cry.
Yeah.
She's like, you're allowed to grieve your patients.
Yeah.
You Because the difference between me and a hospital nurse is the hospital nurses usually only see these patients for a very short amount of time, and then that's it. Right? Like they do everything they can for them, and then that's it. They're goodbye. I come into their homes. I learn their grandkids' names, and I learn their pets' favorite toys, and this is their favorite pair of socks because it's fuzzy, or they love to eat this when they're feeling sad. Like I learn like the the deep secrets of these families, and then I build relationships with their families as well. So everybody's, like I genuinely love my patients, and so she said it's very appropriate to just cry. You're allowed to grieve over losing patients and losing relationship with families and things like that. Like crying's a great one. So whenever I have a hospice death, um, those are like sacred to me, like very sacred to me. I try to be there for every one of my hospice deaths. And I come in, I do the whole visit like I'm supposed to, pronounce the death. I clean the entire body. So not everybody does that, but I completely clean them, change them of all their clothes, like put them in fresh clothes. I usually get their blanket or whatever it is, and I'll even like comb their hair and just make them look like they're sleeping. And then I bring the family in and they do their, like they kind of say goodbye. It's easier for them to see family when they're not, death is not pretty. So it's just easier this way. Um, and then I finish the rest of my visit the way I need to, say goodbye. I go to my car and I usually will like drive down the street, or I'll drive. Sometimes I drive even all the way home and park out front. And then I just like, okay, I gotta like have a grieving moment, and I just cry it out for a minute. Like I've not had a single patient pass where I didn't just cry, because you put so much into them, so
Right.
much love and affection and effort and work into it. And then when it's done, it's like a breath of relief, but then also grief. Like you're just like, like you're just sad. And so I just cried out. Usually I'll get like an ice cream, like a sweet treat or something. And then I usually just kind of feel sad for the day. Like my husband's amazing at just being like, you just need to feel sad today. I'm like, mm-hmm. If he knows I have a patient that's about to pass, my freezer is stocked with Ben and Jerry's. He's so good about like, okay, cool. And then my kids are even amazing. They usually come up and give me big hugs, and they're like, I'm sorry about your patient, mom. And so like those are just like little things that I almost look forward to. Like I know that my kids are seeing that, and I just think like it helps them as well, like
Yeah.
emotionally grow. So it's kind of cool. It
That's
turns into
cool.
like a family thing, but the rest of the day is very like somber, very almost reverent in a sense. And I like it. Like it helps me have closure. But not everybody's like that. Some of our nurses will just, I don't know, they just like don't react at all.
Yeah.
And
Well,
everybody's got different ways to like cope with it. And so,
yeah, I think it's beautiful that you like it's so human to come into that moment of someone passing and to allow yourself to grieve. I think is, and I almost asked the question initially saying like how do you not let it in, but it's almost like the whole point is to let it in, to
mhm,
and the resistance would be what you shouldn't do, almost is
mhm.
what like the perception of that would be, is like to let it in, to let it change you and then continue. And the fact that like your home supports you to be human in having to be just a container for someone is so beautiful, and I'm really happy that you let yourself feel and be human too in this work. Like it is like, I think
Thank
that's
you.
really
Yeah, a lot of nurses will just like try and let it not bother them, and they try and repress it a lot. And I've never wanted to be that nurse that is unfazed. Um, and so I very much am like an advocate for no, let it get to you for a second. I mean, don't let it like ruin your life, or, you know, no more than 24 hours for sure. But I want my kids to always understand that like life is precious and death is serious. Like I want them to understand that and see that their mom, like as a nurse, genuinely cares about people, and like is a human too. Like I don't see them as my patients, I see them as people. And to me, that's good nursing, is to treat every single person like a human being and not like a job. Because then you start hating your job, right? Like if you enjoy it and you enjoy the people you're serving, then you're going to like your job. I love my job. I love being a nurse. I love every second of it, even on the hard days. And our healthcare, we are so overworked and underappreciated. It's so freaking hard to like want to stay in it. We're seeing massive drops in levels of nurses right now. Like nobody wants to be a nurse because it sucks. We get overworked, we're underappreciated, our patients treat us like crap. And I think we get just taught to just like push forward, just keep going, like just whatever.
And it's not.
And I would rather take the time and just find like the little things in it so that I have more longevity in
Yeah.
in the career.
Well, how about this? What about like if some of the families that you've described, some of the families of the patients you've described are like wildly on a roller coaster and emotional up and down, right? I mean,
Yeah.
yeah. So if you had a message to just like the regular person, obviously they're in an emotional state because a family member is dying, but in a logical state, how would you coach a family prior to them having to like deal with the death of someone to support like you as the nurse? Like what would your message be? Like, hey guys, through this time X, Y, and Z, this is the best way that you could help me help you.
So I actually do that every day. So as part of a nurse, one of my biggest jobs is education. So I educate families 24/7. So when I very first come in on a hospice patient, after I'm done with all the assessments and figuring out their story and figuring out what they need, I have to set boundaries, which I guess goes along with the other question you asked, is how we kind of cope and deal. Because I have a work phone, so they text it, they call it. I get phone calls at 2 in the morning all the time. Um, and so I have to set boundaries with my patients a lot and their families a lot. Um, and I have to set expectations. So when I talk to the families, I let them know that the patient is my patient. Like that is my number one priority. So I will do everything that the patient asks me to do because I believe in autonomy and then that's what they get. So as a family member, I need you guys to help me support that. So if Mima doesn't want to eat, if Papa wants to sleep all day long, if Dad wants to do this or not do that or whatever it is, we need to support it. Um, and then I always ask for communication. I'm like, guys, I'm a nurse. Okay. I'm pretty tough. Like, if I'm making you upset, if I'm doing something that you don't understand, if there's ever any question, you have to just tell me or ask me, and you can do it as bluntly as you want. I don't care. It does not bother me. I only care that you feel okay, that you feel comfortable, that you understand what's going on. Because as the family, they're going to start, we get to a point where the patient is not coherent and not talking. And that's usually where we see a really big change in family, where they start either having the acceptance or they start denial, freaking out, panicking, all of that. Um, and it's usually like I never really have to deal with families leading up to that point. But the second that the patient becomes incoherent, we get that split. Um, and so when they do start having the denial, the panicking, all of it, they take it out on the nurse every time. Every time. We have done everything wrong. We are killing their loved one. We deal with pretty heavy drugs, morphine and lorazepam, and so we're overdosing them. We're killing them. We're not doing enough for them. And it's my job to continually educate. Like, I'm constantly saying, okay, the amount of morphine that we're giving is not enough to kill him. The amount of lorazepam that we're giving is not enough to kill them. Um, their oxygen levels are this, their blood pressure is this. Remember that they have terminal lung cancer. This is like a normal progression of cancer. This is a normal progression of death. Like, I constantly am educating them, and then I make them like repeat back to me what they've learned so that I can see holes. A lot of the times I involve them in their care. So I will find like, I kind of like psychologically assess a little bit family members that I feel are really um, responsible or have accepted the terminal diagnosis, because then I involve them like, hey, you're my caregiver, you're my guy. Okay, you're going to be the one that texts me. You're going to be the one that gives the morphine at this time. And I like educate them, and I almost treat them like little baby nurses. And then they feel this like job, like this purpose, and it helps them, like it helps them help me. They're way more willing to help me. They're way more willing to communicate with me if I treat them like they're my guy, like they know exactly what they're doing, and I like walk them through it. So it helps me when as long as my family's educated, that's like my biggest thing, because then I can do my job way easier. It's when they don't have family, or when their family's not compliant or not reliable, that I'm like, we struggle so badly, and it makes my job so hard. Um, I actually have a great story about this one that just not too long ago happened. I have a lady that is only 61. That's it. And she has congestive heart failure and COPD and diabetes and all the things, right? She's on hospice. For about 3 months, I've been trying to meet her family. She has a sister that allegedly was taking care of her sometimes. I'd never met her. I tried for 3 months. My patient gets to the point where she's on dailies. So when they're on dailies, I'm seeing them every single day because they're going to pass. She's still a little cognitive there, but her vitals are declining. Finally, I meet this sister, and she is like not not willing to help at all, not compliant with meds. She just wants her sister to die and get out of her life. And it is horrible because, like, as a nurse, I'm like, how? She's amazing. Like, how could you not want to take care of your sister? And um, there were days where I can only be there for so much time because I have like 10 patients in a day. And so I walked in one time and she was completely naked in a puddle of her own urine on the floor. So there are times like that where I have to call the sister and I'm like, you said you would be there this morning. Like, where were you? Like, your sister needed you. And this lady's like 270, 280.
Yeah.
So I'm like, she's kind of bigger. And so the sister was supposed to be there to like help me get stuff done. And like, it's just, so education is the biggest thing, but there are situations like this where you can educate till you're blue in the face, and it's just people suck.
Yeah.
Yeah. So then it just boils down to like connecting with people on like an emotional level. I mean, I think this is one of the most challenging things that we in our industry figure out as well. Like, how do you take somebody who's, in their emotional mind and bring them to a place of empowerment or just like peace and love? Like with this situation with the sister, like if she doesn't want her sister in her life, then there's got to be some sort of emotional reference point as to why, whether it has to do with the sister or maybe that girl's husband like is mean to her or something. I don't know. It could be something, but there's something
Okay.
emotionally driving that belief system. So, this is the thing that we're trying to figure out. How do we how do we take somebody in that mindset and just go, all right, how can we get them to think more like you, where you're like absolutely a human being, you're empathetic and you're loving, you're this way as well. And how do you inspire somebody to just, like, I don't know if it's see reality, or what do you think that is? What is the difference for you where you can see, well, and maybe the difference if like you have patients who are in hospice and they're ready for death and they are emotionally like okay with it, or in people who are absolutely trying to avoid it. I mean, I think that maybe the family members also feel this I'm looking for a word that describes, like, they're in two places, right? They have a choice to feel like accept it or completely reject it. So how do you think about that?
Gosh. Okay. So, a couple of things. So one, we never know what happens in a home, right? I don't know. I don't know how they were treated when they were younger. I don't know the relationship that people have before I get there, right? And so, and you would like to think the best of people and think that, okay, if a family member's dying, people are going to be nicer and they're going to be loving and forgiving. And sometimes you just don't see it. Like, and you can't, it gets frustrating as a nurse. Like, there are definitely times where I'm like, that this family is so hard. They're so selfish. They're so, but then I have to like take a step back and remember, like, I wasn't there when they were growing up. I don't know the full story. I just know it now. And so a lot of the times I educate family and I try and, when there are hard families, we do get social work involved, and we get chaplains involved and things like that to try and help. Um, we try and help rebuild the relationships a little bit, or at least keep them stable. So we do put effort into that, and it's hard as the nurse because I can only do so much. And I just have to like try and lead by example. There are times where I've had to use logic over emotion. Basically, there was a family that the dad was dying, like, and he was much older in his 80s. Kids didn't really like him. He just kind of he didn't qualify for a long-term care facility. Hospital couldn't have him. It just kind of like got put on these kids. And I don't know the relationship. They told me little things and I can't necessarily blame them for not wanting to be involved in their dad's care. Um, and so I couldn't play the emotional route with it. I had to go logic. And so I just kind of asked very bluntly, I said, okay, what do you want this whole process to look like? And they're like fast and easy and just whatever. And he was going to go fast no matter what. When I got in, he was already so far progressed that time was not going to be an issue. I only had him for about 5 days. So he was already at that point and barely coherent when I came in. So I told the family, um, these are the signs you're going to see. You're going to see rapid breathing. You're going to see hallucinations. Like, he's going to hallucinate. He's going to be in pain. He's going to be agitated. He's going to yell. Those are like normal. Everybody that's dying really kind of goes through moments like that. And it's not in their control at all. It's our body. Our central nervous system does a number on us when we're dying. So I educate them scientifically about how the body makes us react. And then I said, this is how it's going to affect you guys. Like, he's going to yell, he's going to be agitated, and he's going to be in pain. It's going to suck. Like, you're not going to want to see this. Here's what I recommend. And this is like, you give them their medicine, on the dot when I tell you to. You give them this care, you let them sleep, you don't bother, like giving them some peace where normally I would say like, hey, we want to do this. And I would play the emotional card of you want to give them because they'll be in pain and we don't want, grandma to hurt and we love her. We want her to go in peace. I played it more logically, like if you guys give him his meds, he will pass quickly and peacefully and you guys won't have to suffer and watch him die like a slow, painful death if you give him the meds that you need to. So it sounds like really inhumane. And I've only had to do it once, but like I literally just had to use science and like make it like it was more about them than it was about the patient.
Yeah.
Even though really I was giving the patient the best care he could get, the best way I could get it to him. Does that make sense? Like I know it's like really weird,
Absolutely.
but I just had to like
not at all. I mean, you're
manipulate.
absolutely aware of the family and their emotional reference point. They don't really care. And given the situation, you're like, hey, you know what? Well, you care for this man, and then you're also caring for the family. They just aren't necessarily congruent at that time.
Yeah.
So, I mean, hey, I
Yeah.
don't think it's anything terrible.
I think that's the most loving thing to do is to, I mean, your position as a nurse is to care for the patient, and whatever ultimately is to the patient's best interest is what needs to be done. So I mean, I think that is such a loving act to be able to communicate, to read someone enough to communicate what is best for the patient and get that done. Like I think that's great.
Thanks.
Yeah.
Yeah, the psychology degrees definitely come in handy for hospital.
I was just gonna say that
For
was
sure. I double majored in psychology and nursing, and I think I use psychology every single day, every patient, every day. Because then I learned to like assess psychologically too. And so I can get on that level with that patient and talk to them at their level, whichever it is. Sometimes we get really emotional patients or family members, and I have to like really accommodate that. And then we have our really low ones that are like, I literally don't care. I'm like, okay, no emotion, science only. Gotcha.
yeah, crazy.
Crazy.
Mhm.
Okay, well, now I like to switch gears because hey, you've told me some crazy stories. I mean, the bag of human shit. I mean, people, having all these incredibly embarrassing situations, or just like, the medication story with the guy and his wife and you. I mean, there's so many fun stories that you have about the ER stuff. Like give us a laugh.
Okay, so to start, I'm a black cloud. Okay, I always have been. And what anybody in the healthcare field knows that a black cloud is somebody that just like the craziest things happen to them. You never want to work with them. So we have, and then like you have white clouds. White clouds are the people that like always have the calmest shifts, always like nothing ever bad happens.
Yeah.
And I wish so badly I was a white cloud, but I'm not. And I mean, this happened when I was just in nursing school in my rotations. As a psych nurse, the craziest things always happened. Being a psych nurse for severely mentally ill teenagers was absolutely nuts. And dangerous. And these weren't just like kids with behavioral problems. These were kids with actual psychological disorders. Like they should be in an asylum or in jail. So that followed me around, and it was like a joke. There was a day where like even I wasn't even at work, and my coworker called me and he was like, "Are you in the parking lot?" I was like, "No, why?" He goes, "Because this just happened and we literally thought you must be on campus somewhere,
No way.
like messing with us." I was like,
That's funny.
No. So then I always was curious, like, how is this going to translate over to home health?
Yeah.
And it, as Dalton mentioned, it does. It follows. We talked about the guy that deliberately pooped in a Walmart bag and waited for me to get there so he could throw it at me.
Yeah.
Gosh.
And then he begged to touch my hair after, which was really
Hmm.
weird.
Was it
Mhm.
like a solid log or like a wet, drippy bag?
Yeah.
Nice. Good thing
Mhm.
there weren't any. I mean, maybe there was a hole in it. Who knows? I mean, Walmart bags are kind of thin, you know?
Yeah. Yeah. It was rough. It was rough. Um, the the medication story I'll tell you because it was pretty great. I go into a home for home health. It's just a post-surgical assessment and wound care. So he's like 60s, late 50s, something like that. And he has no health history at all, at all. Like he's totally healthy other than this surgery, right? And it's
Yeah.
just like a hip replacement. So it's easy. Part of my job is education for medications. So in my routine, I go, okay, why are you taking this med? How often are you taking it? I know the answer. I'm making sure they know the answer, right?
Yeah. Yeah.
And so I'm going through his med list and I see the medication sildenafil. Sildenafil, I read it and I go, oh my gosh, I also take sildenafil. I take it for my Raynaud's, okay? I have severe Raynaud's. So it helps me with blood circulation. So my brain just goes, he doesn't have any blood circulation problems. He didn't report anything in his home health, like in his health history. So I look at him very seriously and I'm like, why do you take sildenafil? And he was like, why do you think I take it? And I was like, I don't know. And he was, it's Viagra. My wife is hot and I would like to have sex with her.
Oh my gosh.
I forgot it's called Viagra on commercials.
Yeah.
Like I went straight to just, oh, it's sildenafil. Like, duh. We do that all the time. Like, you forget like lorazepam is Ativan or things like that. Like, I forgot sildenafil was Viagra. So I'm
Yeah.
embarrassed. Another thing to know about me is I suffer from foot and mouth syndrome. So
Yeah.
I constantly embarrass myself. And I go, I'm so sorry. I just saw the medication sildenafil and thought, oh my gosh, I take that too. And I couldn't figure out why you take it. Well, now he's looking at me like, do you have a. So he does a full body check on me. And I go, oh, I don't take it for my penis. I take it for my Raynaud's. I don't know why I said that, guys. And he just looks at me and I go, I don't have a penis. And he
Yeah.
goes,
Yeah. Yeah.
okay.
Okay. That's
And I go, I'm so sorry. So how often are you taking it? And he was like, whenever I'm feeling lucky. And I was like,
yeah.
as needed.
Nice.
Gotcha. My
Uh,
bad. So sorry.
yeah, yeah, yeah. Then you had to go cry in the car afterwards.
Yeah.
Yeah,
A
yeah,
little
me
bit.
too.
It was a very long
Yeah,
drive home.
yeah.
I was like, I can't believe I just said that.
What Ben and Jerry's
Um,
ice cream is that?
yeah, right.
Yeah,
That was a
yeah,
Cherry Garcia day,
yeah,
man.
yeah,
I
yeah.
was literally thinking that.
Yeah, yeah.
Cherry Garcia.
I'm a Cherry Garcia
Yeah,
girl.
yeah.
Yeah. I've had patients tell me, oh, I don't know if you remember this one. I had a patient tell me that my face looked like death
Mm.
and I needed to get out. Like she wanted me out of the room. She did not want me to be her nurse anymore because when she saw my face, it made her think of death.
Mm.
And it was like humbling. Thank you. Okay.
What do you think? What part of your face do you think she thought looked like death?
I don't know, man. This whole area. I don't
The,
know.
the whole area. The whole thing.
Yeah, the whole area. I do get a lot of comments on my hair for being black.
Yeah.
It's in southern Utah, you
Mm.
know, we're a little blonde hair, blue eyed over here. And so
Yeah.
I get, I had a patient that asked, long story short, he basically told me that I looked like I was from Las Vegas and I looked like I would make a lot of money in Las Vegas. because of my
Mhm.
black hair.
Nice.
Nice.
So
Uh,
that has been my biggest complaint about home health is there's no security guards, there's no like backup. So I actually carry pepper spray with me everywhere.
Yeah.
Because people are incredibly inappropriate to me
Really?
when I come into their homes. Yeah.
Yeah.
Oh yeah.
They feel
Like
like, well, she's already in here, so all the
pretty
videos that
much.
I watch end well.
Are you always alone? Like it's just you going to homes?
Hmm.
Wow.
Yeah. So that's the scariest part. And that's like that's my biggest complaint for home health is there's just you just don't know. I walked into a home and the guy literally yelled to his wife, "They sent me a really pretty nurse." And she said, "Okay, be nice." And then he proceeded to ask me to sit on his lap. So we get like really and like awkward and inappropriate moments like that.
Yeah.
People just say things and do things that you're like, that you would never do that in a hospital,
Yeah.
but it's because I'm in your home and I'm alone. So
Yeah.
I do carry pepper spray into every home with me. I just don't make it known. Um, and like, you know, I just protect myself the best I can. I have had I've had patients where I go there one time and then I can't go back
Yeah.
because they're so inappropriate. Um, trying to think. Oh, well, I'm trying to decide trying to decide on which stories to tell and which ones not to because my Black Cloud has a genre sometimes. It has a theme, but they can be kind of inappropriate. So a lot of male genitalia in my Cloud stories. Men,
Yeah.
men are the worst.
Yeah.
So part of one of my funnier ones is a part of a education moment was a husband and wife. I'm there for the husband. He had strokes and they're young. They're in their 50s.
Mm.
Um, and he had had several strokes, so he can barely feed himself. Um, can't really speak, but he's there. Like cognitively, he's totally there and he follows everything you're saying. He just can't verbalize it. And he's in a wheelchair. So wife is taking care of him full time. And I've been visiting and educating and helping. And then I go for one of my last visits, it's like my second to last. And she goes, "Okay, I have a problem that keeps happening." I said, "Okay." She's like, "Well, he keeps getting erections." I said, "Yeah, he's a man and they do those. They have those. They do
They do,
that."
they do those.
Yeah, they do those. And she was like, "Well, I keep trying to help him out." "Uh, As a nurse, you're just like, you have to lock in, right?" And you're like, "Okay, great. Good for you. Way to be a good wife." Like awkward. And then she said that she had been rubbing him raw and I had to do wound care for this man because sex education is not as popular as we wish it was. And she had been using Medi honey, which is like medical honey for wounds. It's honey to help him out. And antifungal foot cream was the other thing she was using.
My gosh.
And never in my life did I think as a nurse I would have to educate a 50-year-old woman on sex ed
Yeah.
and infection risk and do
Yeah.
wound care on a man that literally was bleeding.
Yeah.
Hmm. So yeah, there are things like that that happen, and you just like as a nurse, you're like, I never thought I'd have to say these words. I
Yeah.
never,
Yeah.
I never thought I'd have to educate on this one,
Yeah.
but
Yeah.
here we are.
Here we are. We
So
when I was in the military, my job was public health when I was deployed, and we had, incredible stories about just personal hygiene, even for soldiers. I mean, we all go through the same training, men and women, and
mhm,
like literally everybody has to be taught personal hygiene, taught to do their laundry, taught to do like that is part of military training, is that. And then
mhm,
you go deploy, and then you have all these really just kind of shocking stories, females not knowing to take out a tampon, and they just put like 20, 30, they just put a new one in, and they're just
Yeah.
there. Like, I mean, it's not like every day. I mean, like, they're there for weeks, and then they end up getting like sepsis or something,
Yeah.
crazy infections. They're whatever, they're urinating, they're out in the desert, it's all fucked up.
Oh yeah.
So yeah.
I've had to educate women on things like that all the time.
Yeah.
Um, I've had to, we had a lady that was so mentally ill. This is in my time in BMed, in the BMed unit in Southern Utah. And we had this lady that hadn't showered in 2 years.
Whoa.
Yeah. So her hair was
Fast.
matted. It was just a giant, and it smelled so bad. You could smell her from down the hallway. She is terrified of bathrooms. She had
Why?
something traumatic happen in a bathroom. She's afraid of bathrooms. So I asked her, I said, well, what do you do when you have to go to the bathroom? She says, I just changed my underwear.
Wow.
So she hadn't showered in 2 years. Her skin looked like lizard skin. Like it was
Crusted.
flaking off. It was dark. It was like significantly darker. The only light parts on were like around her mouth and around her eyes where she would like rub or eat.
Huh.
And like as a nurse, you come in and you just look at this patient and you're like, oh, gross. Like, oh, sick. Like, I don't want to do this. But then
Yeah.
you go, okay, wait, she needs help.
Yeah.
Yeah.
And there's so many times, like, as a nurse, where you're just like, or you just, because this was preventable.
Yeah.
Like, there are so many dumb things that people do, and you're like, we could have prevented this entire thing. But you have to, like, lock in, remember that they don't have the same education or same mindset that you do.
Yeah.
And you literally have to like channel that inner compassion for people and like, okay, all right. And then you like help them. It's so funny. Like nurses have so many different stereotypes about them. Like we're all ADHD, we're all extreme emotion, like tattoos and energy drinks and alcoholics and all the things, right? We get a lot of we're the most introverted extroverts you'll ever meet
Yeah.
because we just talk to people all day long and we're like educating and we're giving them our all. And then we go home and we just completely recluse, like go under a blanket and hide for days because it's so exhausting. And like nurses love people and hate people the most out of anybody else.
Mm.
It truly takes like the most Christ-like godly love to be a nurse, I think, genuinely. To go to whether you work in a hospital or you work in a facility or you work in people's homes, you have to have like an immense amount of love and compassion for people that is just like unmatched
Mm.
to want to take care of people that can't take care of themselves or probably should and just don't. And but also it's very justified when nurses say that they hate people.
Yeah.
We see the worst of people and we get the worst things happening to us. And um yeah, we understand why warning labels are made for
Yeah.
sure.
Yeah, for sure.
I just had a patient that called me at 2 a.m. and he said, I fell and I think I broke my wrist. Now, he's hospice. Hospice has a strict rule. We don't go to the hospital. You call first and we assess and do what we can, right? Because insurance is a
Yeah.
whole other monster we deal with. So I said, okay, how broken? And he's like, it's broken, but it's just swollen. Like, I don't know if it's broken. It just hurts and it's just swollen. I said, okay, I'll be right over. And he goes, no, 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 you're okay. Um, and I said, well, then you need to go to the hospital because a broken wrist means hospital. And he goes, honestly, I think it's just sprained. It'll be fine. But if you could come over in the morning, I would appreciate it. And I'm like, okay, that's not abnormal, especially for
Right.
a broken wrist. A lot of the times the ER is going to just splint it, which I can do.
Yeah.
And then that's it.
Yeah.
So I make it my first appointment. I drop kids off at school and I run over there. bone is sticking out.
Sprained.
It's a good sprain.
It's a pretty good sprain.
Yeah.
It's pretty-
And I'm like, just swollen. He's got like blood. Like it's like literally like open exposed bone.
Yeah.
So now I'm calling family to come get him because I can't legally drive him to the hospital. Family's like, well, we can take him, but it'll just be a drop off. Okay. So I meet him at the hospital. I take him straight into the ER. I've already called and I'm like, listen, this is the report because he's
Yeah, yeah.
hospice, so they have to treat him different. But like
Yeah.
we get situations like that where I'm like, you know that this is bone, right? And he's like, yeah, I was hoping it wasn't. And I'm like, but you knew. And you
Yeah.
didn't do it. Like,
What else could it have been? Like a pencil you forgot in your wrist?
Yeah.
but this is what I mean.
Yeah.
Like,
Yeah,
this is what I mean. Like, as a nurse, like you're like, okay, there was common sense. Like you knew,
Yeah.
but you didn't want it. I had another patient. I came in and two of his toes are hanging on literally by bone, and that's it. I can see the bone all the way around. It's
Mm.
black. It's necrotic. His toes need to come off. And I said, why didn't you go to the emergency room? And he said, well, I knew you were coming in like 3 days, so.
What happened in 3 days that he got necrotic toes?
He's diabetic. So I wasn't there for that part. I was there for a different reason.
Sure.
And then he just never reported that his toes were bad because
Right.
diabetics, sorry, have neuropathy in their feet. So they a lot of the times can't feel their feet. There are times where a person with diabetes will step on a nail and not even know it.
Yeah.
And like their toes fall off all the time because there's so much damage and they don't even know that there's damage.
Yeah.
But the problem is that he did know there was damage, but just thought that the home health nurse was going to fix it in 3 days.
Wouldn't it be funny if you just like came and like cracked his toe off? You're like, all right, should be good, bro.
There are
You're like,
times where I'm
yeah,
like, I could probably
Not even-
just, I
yeah,
could fix
just-
this.
yeah. I need that. You're fine, bro.
Yeah. This is random, really random, but I did think of a black cloud story for hospice. This is one of the craziest things. One of the craziest things that has ever happened to me as a hospice nurse, and none of my coworkers have ever experienced this either. So, this man is 89 years old, so he's old. He's getting dementia. Oh, he has dementia, low key Alzheimer's. It's like a weird, not quite, but it's more severe than dementia. It's kind of weird. But anyways, he was ready for hospice. And I'm taking care of him and I have him on hospice. And then we get to the dailies and we get to the point where he's going to pass. Family calls me and I usually like to leave my families with a pulse oximeter and it tells me how much oxygen is in their blood right now and what's their heart rate. So I educate the family when it gets to this level, you call me. When it gets to this level, do this med, whatever. It gets to the level where they call me. I come out there, I'm sitting with him for probably 30 minutes and I'm like, yeah, he's going to pass. So I don't leave. I'm sitting with the wife, she's holding his hand and he passes.
Yeah.
And he takes like this last breath and then it takes her probably like a solid minute to realize that he has passed. And I'm just I'm letting her figure it out.
Yeah. Yeah.
So she realizes and she looks at me and she goes, is he dead? And I said, I'm going to pronounce death in just a second because that's a whole thing I have to do. Let me go grab the daughters and bring them in here. And so I bring them in. And at this point, he's been gone for probably like 2 minutes.
Yeah.
I set the timer on my phone because I have to listen for 1 whole minute and make sure nothing is there. I do that. It's been over a minute that I'm listening and I'm just about to call it. And my head, I've got my stethoscope and my head is like right by his head. And I look up at the wife to tell her, okay, time of death. And he breathes. He does this like, and I panic. And I'm like, oh my gosh. And my both feet came off the ground. I jumped so hard. And he continues to breathe. He continues to live for another 45 minutes after being dead for 3.5 minutes.
Crazy.
Yeah. So the family's traumatized. They're crying. Um, I'm traumatized, but I have to like
You still have.
composure because
Yeah.
I've never seen somebody come back to life like that. And then the wife is like, "Are you okay to just be in here? I just need a minute." And I'm like, "Oh yeah, no, no, take your minute." But at the same time, I'm like, "I don't want to be in here." Like,
Yeah. Yeah.
so I'm talking to the patient and I'm like, "Are you you? Is that did something hop into your body? Like, did they send you back? Like, what
Yeah.
happened? Like, why are you alive?"
Yeah.
And he never woke up or anything, but he passed about 45 minutes later, and he was dead for 10 minutes before any family members would come in.
Wow.
And like I kept leaving the room like to talk to them, and then I'd come back and like make sure that he's for sure gone because it was traumatizing the first time. I did call my friend that works in the ER. He's an ER doc. And I was like, "This happened." And he said, "Yeah, that's called the Lazarus effect." So it's like an actual phenomenon that happens. And people see it in the ER a lot. But that was the first time for our hospice company to have that. And of course I had to go tell all of them, like,
Yeah.
this just
This is a
happened.
big- yeah. Yeah. Yeah.
It was the
Yeah.
craziest biblical phenomenon I've ever heard in my life. Like, it was insane. But that was probably one of my craziest hospice deaths. I've had like traumatizing hospice deaths where family doesn't take it well, and um, I had to listen to the heart. Well, I had to listen to the dead body 3 times in a 2-hour period
So
because
then, yeah.
they wouldn't believe that they were dead.
Hmm.
Like, they just kept thinking I was a bad nurse or I couldn't hear right, or that like denial is it's a ugly monster. But that was one of my more entertaining, I guess, hospice deaths. Was the Lazarus effect. It's a real thing, and it was terrifying.
Sounds terrifying.
Yeah.
But of course it would happen to me.
Yeah. Yeah. That's funny.
Mhm.
Well, I know that you said you have
Mhm.
fun and exciting plans for the rest of the day.
Yes.
I do.
Um,
Yep.
So thank you so much for sharing your world with us. I
Yeah.
mean, it's awesome. I appreciate you coming on and just being real. What do you
Absolutely.
what do you want to leave everybody with?
Well, I also just I appreciate you coming on and sharing. Personal like exposure. I read The Five Regrets of the Dying by Bronnie Ware, and so like this is
It's
so
so good, huh?
so good, and it's
Mhm.
so wonderful to hear like that connection being made. Is like, yeah, this is like such a it's an honorable life, I think, to live your life so close to death, like you were saying. So it really is. Um, your voice is so powerful and impactful for the world to hear, because most people, like you were saying, like just aren't aware, or
Yeah.
want to ignore death, or want to treat it as something to put away. And it's like we can actually handle it, and it's our choices that we make every day to not end up in situations that could have been prevented. So just thank you,
Exactly.
and for what
Yeah.
you do for the world. It's beautiful.
Yeah, thanks.
Absolutely.
Yeah.
Yeah. There's an amazing book written by a hospice nurse. It's called The In Between. I would 100% uh, recommend it. It's a lot of like hospice, but it's a lot of just like having compassion for people and understanding that everybody's situations are different. Nobody's the same. And it's just an amazing book for whether you're in the healthcare field or not. It brings closure, and it just really shows that, people can come together in tragic times like that. So it's a great book. I would highly recommend it. I read it, highlighted it, bookmarked it, the whole bit. So it's a great book.
I will absolutely look into that.
Nice.
Yeah.
Well, cool. Well, thank you so
Yes,
much.
You
thank
guys,
you.
Love you lots, hearts
love
all
you.
around. And
Yeah.
I want to get you on for another one because
Yeah.
it was fun.
I thought this
We'll
was
have to do one where it's just the crazy stories.
Yeah, we'll go
'Cause-
deep on something, or maybe we'll think of like ways that we can merge what we're doing in healthcare and what you're doing in healthcare and create a world-changing idea. Who knows?
Yeah, we could talk about healthcare abuse.
Yeah, sounds good. I like it.
Okay. Alrighty, guys. Have a good one.
Yeah, you too. Bye.
Thanks. Bye.